In just a moment. Thank you all for being here today. All right, well, let's get started. Thank you all for being here. We're very happy to have you. We've got an exciting program lined up, and we'll get started on with that in just a moment. First, just a few tips and informational details. For those who are not familiar with Zoom, I think we're probably all very familiar with Zoom by now, but just in case, please mute yourself during the meeting, especially if you have background noise. And then also, if you would like to submit a question or a comment, there is a chat feature. Just look at the bottom of your Zoom window and you'll see a chat button, and then that'll pop open a text box where you can type in a comment or a question. So I'm going to just present a little bit of information about iConquer-MS and what's going on these days. So one of the things we wanted to feature is our Cover MS study, COVID-19 and MS. If you're a member of that study, wonderful. This is looking at the impact and the effectiveness of COVID-19 vaccines for people with MS, and we're thrilled to have you be part of that study. We are currently doing a sub-study where people are contributing blood samples to be tested for antibody and T-cell responses. So if you've gotten an invitation to join that sub-study, please consider being part of that. We also have new Real MS surveys available, and Real MS stands for Research Engagement About Life with MS. This is our prospective study where every 6 months we ask our members to update their information about how you're doing and what you're doing to help manage your MS. And Real MS will also give you access to your data over time and show you how things are going and how you might be comparing with other people. So be sure to check out those features too. And I also wanted to highlight our new research projects page. And this is an area on the iConquer-MS website. You can see the URL right here, iconquerms.org/research-projects. And we posted that just a couple of months ago, and it's where we summarize the research that we're conducting with you as part of iConquer-MS and give summaries of what we're learning. And over on the right-hand part of the slides, you will see a summary of the study that we'll be discussing today with our presenter. So after today's webinar, I hope you'll go check that out, and you can learn more about what the study was about and also how you can find out more. So that is it for me, and I will now hand it over to our host, Chat, who will introduce our speaker, who will talk about lifestyle behaviors on health outcomes in people with MS. So Chat, it's all yours.
Thank you, Hori. First of all, again, thank you so much for all being here. For those of you who haven't been here before, just like to kind of give you a little bit of background. This is the webinar that with the iConquer-MS, and we name it Chat with Chat just because of one reason, because my name is Surachat and I go by Chat. So that's why we named this webinar here is a Chat with Chat. So that means that if you are comfortable to chat at the end, I would be you are welcome to do so, to ask question and answer. I mean, and then we will answer. But if you like to just observe and listen, you can do that as well. Okay. So again, my name is Chad. I'm a faculty at the Harrison College of Pharmacy from Auburn University. I'm going to be the host of the today webinar. And as Holly mentioned, today we're going to talk about the title of the webinar is assessing the impact of lifestyle behaviors on health outcomes in people with MS. So we have a guest speaker. In fact, today we have the first time that we have international, outside the US guest speaker. So we have Dr. Nupan Naik. She is, let me introduce her. Here, and she is a senior research fellow and also the deputy head of the neuroepidemiology unit from the University of Melbourne in Australia. So from her personal experience with health management to lifestyle, Dr. Nek has been a strong advocate of the eight pillars of the good health for 17 years. And she completed her PhD degree in neuroscience from the University of Melbourne, followed by international postdoctoral training when where she investigated the cholinergic system and also environmental interactions in the Rett syndrome and the efficacy of potential therapies for treatment of ataxia. And in 2017, she transitioned to public health research with aim to improve patient-informed decision-making, health outcomes, and also care. So Dr. Nek research focus on is to assess how lifestyle behavior such as diet, supplements, vitamin D, mindfulness, and physical activity impact on the secondary prevention and also management of multiple sclerosis and also other chronic diseases or illnesses. She also interested in the digital health education for positive behavioral change. And here we are, Dr. Nek, please take it over.
Thank you, Chad. Thanks everyone for attending today. I wanted to start by acknowledging the traditional owners of the land on which I'm speaking. I pay my respects to their elders past, present, and emerging. So what are lifestyle behaviours? The 8 pillars of good health are commonly defined as physical activity, healthy diet, stress reduction, social engagement, quality sleep, cognitive engagement, spirituality, and altruism. And these positive behaviours have the potential to prevent and manage chronic illnesses. I love this quote by Dr. David Katz, who's located in the US, and he writes, "Lifestyle as medicine has the potential to prevent up to 80% of chronic disease. No other medicine can match that." In terms of research in people with MS, the general focus are on these 6 modifiable lifestyle behaviours. And this is primarily because research has shown that some of these, including deficiency in vitamin D and smoking, are associated with increased risk of MS, while others are associated with better health outcomes. And that's what I'm going to be speaking about today. So people with MS may experience a multitude of symptoms which can lead to a reduced quality of life. When we refer to quality of life, there are several components encompassing this, but when we research people with MS, we generally focus on physical and mental quality of life, and that's primarily because the main symptoms, some of the main symptoms are depression and mobility impairments. So the current treatment for MS is to manage symptoms and reduce disease progression through use of DMTs and through lifestyle. And the aim there is to mitigate the symptoms and slow disease progression, which in turn improves quality of life. The image here shows proportions of people with MS reporting to experience the specific outcomes based on a US population. So the values there just show, and in our research, we look at depression, fatigue, walking difficulty, and mental and physical quality of life. So the neuroepidemiology unit, which is where I work, is a small group of 8 researchers and students at the University of Melbourne in Australia. And this was founded in 2006 by Professor George Jelinek and is currently headed by Associate Professor Sandra Mead. And our main priorities are to assess how do modifiable lifestyle behaviours impact health outcomes in people with MS. So why do we want to study lifestyle and its impact on MS? DMTs may not be 100% effective. They may not be accessible to everyone, and they may cause potential adverse effects. So lifestyle can provide a safe and affordable means for care. Lifestyle may be used as a potential for treatment to manage symptoms, slow disease progression, and improve quality of life. And this is what we're interested in assessing. The studies may provide insight into personalised care that is specific to the needs and ability of the individual. So you might see differences in people with progressive MS versus non-progressive. And that's also something that I'll be talking about in the talk today. Lifestyle also offers the individual to take care of their own health, which leads to overall well-being and reduced risk of other chronic conditions, as well as empowerment of being able to control their life as well as their disease progression. How do we research this? So there are generally 3 research designs, and this is randomized control designs, observational studies, or qualitative research. And the main differences is how the participants are allocated. So with an RCT, it's a random allocation. Observational is just observing the natural behavior in a real world situation. So it's a natural allocation. And with qualitative research, it's either through a survey response where it's an open-ended question where you're able to write your free text opinions, or it's a direct interview with the researcher. So the slide here highlights the positive aspects of each of these study designs. And we're interested in observational data when we study lifestyle. And this is important because, as I said, we've got real world data when we use observational studies. And when people follow lifestyle, they generally tend to follow more than one. So if you're following a healthy diet, you're more likely to be following a healthy exercise regime, for example. And this is more evident in observational studies. The other important aspect is that we're able to have a long-term follow-up. So we can follow up people from 1 to 10 years or however long the funding allows. And this is important because changes in health outcomes may not be immediate as what you might find in a drug trial. So it's good to see the changes in health outcomes, especially with something that may progress slowly, such as disability. We want to see what the effects are over several years. So all the research today I'll be talking about is based on observational studies. How do we source and access this data? In a global collaboration, which included researchers from Accelerated Cure and NEU team members, we published a summary of data sources available around the world and their key components. We scoped the literature and identified 62 data sources that had information on people with MS. And each of these custodians were invited to contribute to the study, of which 38 agreed to register. We analysed and compared the 38 cohorts, and what we identified is that the data capture was common, was demographics and disease characteristics. What was less common were information about fatigue and cognition, and even fewer collected information on lifestyle behaviours. Of the databases, the ones that collect lifestyle behaviours were Holism, the Health Outcomes and Lifestyle in a Sample of People with MS, as well as ICONCA MS. And these are the 2 data sources that I've used, and the results from today's talk will be presented based on these databases. Both Holism and ICONCA MS are longitudinal observational cohorts. And using this data, we can either perform cross-sectional analysis, and this means that the data is analysed at a single time point. We can also do longitudinal assessments where the data on the same population is analysed at multiple time points. Most epidemiological studies are cross-sectional, and that's just primarily due to cost, data availability, and sample size. These are really important as they demonstrate the associations and inform the direction that researchers should take and invest in for longitudinal studies. And the longitudinal studies are of most value because they allow us to be more certain of a relationship between lifestyle and outcome. For example, if you had a cross-sectional study looking at diet and quality of life, you don't know whether the quality of life was better before the person has implemented the diet or whether it happened after they've implemented the diet. Whereas with a longitudinal study, you can look at the person has implemented a diet or lifestyle behavior at time point 1, and you analyze the effects at time point 2 or 3 on the health outcomes. So it allows us to have a causal relationship analysis. So holism, which is from our unit, is a longitudinal study comprising almost 2,500 participants from 66 countries around the world. The participants were requested to complete a 100-question online survey every 2.5 years, up to 75 years. And the data collection ceased in 2019. This table highlights the key findings that we found to date from holism, and the 6 lifestyle behaviours that we're focused on are based on evidence showing that these are associated with risk and progression of MS. The outcomes on the top row are selected based on the impact on people with MS and also the ability to capture this data via validated tools. The downward arrows indicate a negative association and the upward arrow a positive one. For example, if we look at non-smoking, non-smoking is associated with reduced risk of depression, reduced risk of disability, and an increase, and a higher quality of life. The red boxes highlight research where we've extended the analysis to longitudinal studies and found that the associations persisted. Therefore, we can be more confident that the effect is true. So we've shown that healthy diet is associated with reduced disability over 7.5 years and increased quality of life. Vitamin D supplementation use is also associated with higher quality of life, and meditation practice with lower depression. Some of these longitudinal analyses are yet to be completed, so just because there's not a red box there doesn't mean that the association doesn't exist. The main limitations of our holism findings are attrition and participant bias. And what I mean by this is that over time during follow-up, the people that return to complete the surveys were healthier, of higher education, higher socioeconomic status, and they were engaging in more healthier lifestyle behaviours. So our results may not be generalisable to the broader MS community. To address these limitations and validate the results, we wanted to replicate the studies using a different population of people with MS. We scoped the literature for data sources collecting lifestyle behaviours and found real MS. And this study comprises over 7,500 participants across 58 countries, and it captures online health data at 6 monthly intervals. As we wanted to validate our findings from holism, we had to determine which variables were collected across the 2 data sets. What we observed is that the lifestyle and outcomes were generally aligned. And so in our analysis, we wanted to include all the lifestyle behaviours that were matched, and we focused on quality of life and disability as health outcomes. This slide just shows a flowchart of the research process that's involved. We first submitted a research proposal to Accelerated Cure. Once that was approved, we applied for ethics approval to conduct the study through the University of Melbourne. When that's approved, a legal agreement is signed and payment to access the data is made. The data is then identified, so all the names and contact details of the participants are removed and then securely transferred to the researchers. We then clean the data and analyze it, and this is the longest process in the research methodology. Once we have that data analysis completed, we interpret the results and write up the manuscript for peer review, and then finally, hopefully, for publication. So all publications from NEU are open access, which means that they're freely accessible by PubMed. And if you're unable to find them, please feel welcome to email me. While we wanted to validate the findings from holism, we also wanted to ask something more so that we could add to the scientific knowledge. Our research question therefore extended to assess whether associations of lifestyle behaviours and health outcomes are dependent on MS phenotype and MS duration. Why is this important? So it increases our understanding of potential lifestyle interventions because it's able to validate or refute the holism findings in a different population of MS. And it also informs the impact of potential additional lifestyle behaviours that may be involved, which are not captured by the holism data set. Secondly, assessing differences between phenotype might provide insight into personalised treatment for non-progressive versus progressive MS types, and duration analyses may provide insight into whether associations change over the disease course. So we restricted the real MS data to participants aged over 18 years with a confirmed clinical diagnosis of MS, which was self-reported, and who had completed lifestyle and outcome surveys of wellness, diet, exercise, quality of life, and disability. This resulted in a study population of 1,108. We ideally wanted to conduct longitudinal studies. However, when we looked at the number of people who had completed the 6 or 12-month follow-up surveys, this was only around 300 to 400 people. So it's not really feasible to do robust statistical analysis on these, and therefore our study sample and analysis remained cross-sectional. This table shows the demographics of the 1,108 people who were included in the study. So here you can see they're majority female, as what was expected given the ratio of MS from male to female is. Oh, sorry. That was my cue to stand up and stretch. As expected, it was majority female because of the 1:3 ratio of male to female. The population is highly educated, with 70% having a university degree, and 73% were in a relationship. Of the study sample, 68% reported a non-progressive phenotype, and 74% reported being diagnosed with MS for longer than 5 years. Of the surveys included for analysis, physical activity was queries using a validated tool, while other lifestyle behaviours were captured as tick box list of items used or tried in the past 6 months. Ideally, we would have liked to have analysed some of these specific diets and wellnesses on their own, but the numbers for a few of those were quite small. So what we did was recategorise those diets based on the literature into 4 categories for diet and 3 for wellness. For example, an anti-inflammatory diet did include gluten-free and intermittent fasting diets, whereas low saturated fats might include the OMS diet as well as a vegan diet and others. In terms of wellness, an example of mind activity is meditation and stress management, whereas mind-body would be yoga, Tai Chi, Qigong, and other encompasses 17 different wellness activities with a broad scope from acupuncture to hypnosis to massage. The third column just shows the proportions of participants within each of these characterizations, and you can see they're generally the same, and we do have a high proportion of people taking vitamin D supplements. The primary health outcomes we assessed was quality of life, and this is measured using the NeuroQol, which is a validated tool for the general population. And this comprises mental, physical, and social quality of life. And each of those have got subdomains which are listed underneath. And these subdomains are the ones that are scored for the analysis. We also assessed associations with disability, and this is measured using the validated patient-determined disease steps tools, where the participants self-assess as normal to bedridden based on written descriptions. The scores are then consolidated to mild, moderate, and severe disability. Our first study assessed whether associations between lifestyle and health outcomes differ by MS phenotype, and this was published in the Journal of Personalized Medicine in November 2021. 2021. I want to spend a few minutes explaining how to read this table, as the subsequent results tables will be presented in this slide. So here in column 1 is the lifestyle behavior. In this slide, we're looking at diet and the 4 categories underneath. Across the top in the row is the 3 main domains of quality of life: physical, mental, social. The group differences in non-progressive or relapse remitting MS versus progressive types of MS are there. Now, a plus sign indicates a higher quality of life, and a minus sign a lower quality of life in one or more of the subdomains within each of those categories. So it's not an overall score. It just means that one or more of the subdomains are positively or negatively associated. The grey highlighted cells indicates a significant difference between the 2 groups, in this case between progressive and non-progressive phenotype. Let's take, for example, an anti-inflammatory diet. This was associated with higher mobility, which is a subdomain of physical quality of life, and this was evident in progressive MS types. There was no significant associations in non-progressive MS types. Anti-inflammatory diets were also associated with higher life satisfaction, a subdomain of mental quality of life in progressive MS, and associated with higher stigmatization in non-progressive MS. In the interest of time, I'm not going to detail each of the subdomains that are associated, but you can find out about these in the manuscript. The key point is that specific diets are associated with physical and mental quality of life, and this appears to be dependent on phenotype, which suggests the need for phenotype-specific research and recommendations for MS management. As diet is associated with quality of life, future studies should assess nutrition in detail and also include information on duration of and adherence to dietary modifications. With wellness activities, we observed associations in non-progressive MS only. These were positive between mind-body activities and mental and social quality of life, and negative with mind and other activities, which suggests that mind-body activities such as Tai Chi and yoga and Qigong, which are more likely to involve physical and mental interactions, as well as social interactions, are most beneficial for quality of life. The phenotype difference was observed between other wellness and physical quality of life, again highlighting the need for phenotype-specific research. It's important to note that specific recommendations for a practice of lifestyle can't be made, as the categories include broad activities. For example, with the other wellness activities, this includes 17 different practices, which range from massage to hypnosis, so they're quite different. Also, the participants can select multiple activities that they've undertaken in the past 6 months, and the question asks whether they've tried any of these lifestyle behaviours. So it could be that the person tried a particular diet, supplement, or wellness activity once or twice and for a short amount of time, or it could be that the person has followed that behaviour for many years and we're unable to collect that information. Therefore, future studies should aim to access individual wellness activities because they are certainly impacting quality of life, and we should aim to include the capture of practice duration and adherence, which I'll be repeating throughout the talk. With exercise, the level of activity is based on exercise expenditure. So active physical activity could mean 1 hour of swimming or 3 hours of walking over the past 7 days. Moderate and active exercise was associated with higher quality of life in all domains of non-progressive MS types. And in progressive MS types, moderate exercise was associated with higher mental quality of life and active exercise with higher physical quality of life. The difference between phenotypes was observed in active exercise. The double plus indicates a stronger association in that group of people. So exercise is important for quality of life and should be incorporated as a part of MS care. And future studies, as mentioned with all lifestyle behaviours, should capture data on practice duration and adherence so that we're able to better understand and inform potential interventions. These findings have been summarised on the ICON-KMS website, and the peer-reviewed manuscript is free to access via PubMed. We also assess the associations between lifestyle behaviours and disability, but only observed associations with exercise, in that active exercise was associated with lower disability in non-progressive MS and lower severe disability in progressive MS types. No significant difference was observed between the phenotype, suggesting that exercise should be encouraged for all people living with MS. Future studies might consider assessing the type of physical activity. For example, is strength or aerobic better for optimal outcomes for quality of life? So to summarise the study of the phenotype differences, the associations were observed for diet, wellness, and physical activity, but not for supplements with quality of life, and these differed by phenotype. The associations were observed for exercise and disability, but not other lifestyle behaviours with disability, and these did not differ by phenotype. As the analysis is cross-sectional in nature and the categories of lifestyles are broad, specific recommendations can't be suggested. However, given that the literature shows a large body of evidence that the exercise is beneficial for overall health, exercise should be encouraged and supported. And as with all cross-sectional studies, the longitudinal analyses are required to observe a causal effect. Our second research question was to assess whether associations between lifestyle and health outcomes differ by MS duration. And as I mentioned earlier, this may provide insight onto whether these benefits or associations change as MS disease progresses. What we found is that low saturated fat and other diets categories were associated with lower physical and mental quality of life, with people with MS with having long duration of MS, so anything greater than 5 years of MS diagnosis. And these associations differed by MS duration. So the negative association may be interpreted in different ways. For example, diet categories may not represent diet quality. You may be a vegan, but you could be consuming potato chips daily, which are high in saturated fats, but you're still within the low saturated fat category. Alternatively, the diet may have been tried once, or different diets may be tried, but they're not adhered to for a long term. It may be that the diet isn't beneficial if modified late after diagnosis, or that people with longer MS duration have lower quality of life, and these are the ones who are seeking out dietary interventions. So it's difficult to know what's going on with the cross-sectional studies. The key point being is that, again, diet is important for a quality of life and appears to be different based on the length of disease duration you've had for MS, so future studies are important and necessary. As with prior research and with our findings from study 1, a positive association was found between exercise and quality of life. Moderate activity was associated with higher mental and social quality of life in people with longer than 5 years of MS duration, but not in short duration, which may indicate that people with longer MS have been engaged with exercise as a part of their daily regime to manage their MS. Active exercise was associated with high quality of life in all 3 domains, regardless of MS duration, and these associations were stronger for mental and social quality of life in people with short MS duration, as indicated by the double plus sign. Excuse me. This suggests that early adoption of physical activity post-diagnosis may be optimal for quality of life. Active exercise is also associated with lower disability, regardless of MS duration. This was stronger in people who had MS for less than 5 years, suggesting early adoption of exercise is likely optimal for reducing risk of disability. So to summarize study 2, the associations were observed for diet and physical activity, but not for wellness or supplements with quality of life, and these differed by MS duration. The associations were observed with exercise and disability, which also differed by MS duration. As with study 1, these findings need to be confirmed through longitudinal analysis, and detailed assessment of nutrition are needed to better inform the relationship of diet with quality of life. Physical activity should be encouraged early post-diagnosis. While the limitations of our real MS studies prevent any conclusive recommendations for implementation, the findings mostly align with our findings from Holism in showing that specific lifestyle behaviours benefit quality of life and disability in people with MS. They also extend our knowledge, showing that a diverse range of lifestyle behaviours may play a role in managing MS health outcomes. And this is important because different options enables accessibility and also potentially motivates people to adhere to those behaviours long term based on their individual interests, abilities, and are able to afford these behaviours. Some of these associations are dependent on phenotype and duration, suggesting that future research needs to assess these differences in detail to better inform potential lifestyle interventions. The take-home message is that lifestyle is associated with better health outcomes and appears to differ by phenotype and MS duration. So where are we going next with these studies? For Holism, we're assessing whether there are additive benefits to engage with multiple healthy lifestyle behaviours. So if you follow diet, is that enough? Or do you need to follow all 6 lifestyle behaviours to see optimal effects on your health outcomes? And which, if any of these 6, are the most important or impactful to your health outcomes? We're also trying to assess whether these lifestyle behaviours can predict the long-term trajectory of outcomes such as fatigue and disability. future research using real MS, we hope to extend our analysis to longitudinal studies. Now, I showed initially in this methodology slide that the participants who completed all 4 lifestyle surveys at 2 points were only around 300. But if we now focus on exercise and quality of life and disability, which was shown a clear positive association and also uses validated tools, we may find that we've got a greater number of people who completed the follow-up surveys, and we may be able to further extend on these analyses to confirm any causal effects. For long-term future studies, we would like to collect new data, where we'd like to assess whether timing, duration, and adherence to engaging with these lifestyle behaviours matters. For example, understanding what the person's lifestyle behaviours were prior to their MS diagnosis, and when after diagnosis they adopted any new or additional behaviours. And also, what is the level of adherence in terms of frequency, like how often do you exercise or practice meditation, and stringency of adherence. So how stringent are you with your diet when you follow a vegan diet? Are you always vegan, and do you have a healthy diet, or do you sometimes cheat and have a less healthy diet? So we need your help. It's important that participants complete all surveys at all given time points, which enables researchers to undertake robust analysis. Please encourage others to contribute to research. Real MS has ongoing recruitment, and new people are welcome to join at any time. At NEU, we're wanting to recruit participants with MS for a study on online health education. And this will commence in early 2023. So if you're interested in finding more, please do send me an email. Speak to your health professional about incorporating lifestyle as a part of your routine care. The more awareness informs on what is important to people with MS and the support that's needed for them. Speak to researchers. Let us know how we can improve our research to help the MS community. And together, the aim for the impact is to gain insight for strategies for improved outcomes for people with MS. I'd like to acknowledge the participants of Holism as well as Real MS for their data contribution and time to give the information for us to use. I'd like to thank past and present NEU staff and students. I've only just shown the results in one slide, but this is years of analysis and data conducted by many different staff and students. The data that I've presented today using the Real MS data was analysed and cleaned by Ms. Maggie Yu, and the funding for this project was provided by philanthropic gifts to the NEU. Please feel welcome to contact me by email, or you can follow me on Twitter, and you can also connect with me by LinkedIn for any professional affiliations. Thank you for listening.
Well, thank you so much, Dr. Nek. We actually got a few questions in the chat function, but I just like to ask if there is any participant would really like to kind of speak out and also ask our speaker your questions first. Kind of like to give that opportunity first. Anyone would like to ask the questions, your questions? All right, hearing none, I'm gonna start with the question in the questions in the chat function. So I don't know if you actually can comment. There was a gentleman talking about the exposure to mercury, and it seemed like after he kind of stay away from the from the mercury, it seemed like her SPMS, which is the secondary progressive MS, kind of subsiding, I guess. Correct me if I'm wrong, Tom. So then, but the MRI still show, that he has MS. So do you think that this might work for the other secondary progressive MS patients? Can you comment on this?
So Tom, I don't know about mercury exposure. We don't collect that data, but thank you for sharing that information. And I think some things work for some people and others not. So with all these data analysis, it depends on what data is collected. I don't know anything that is collected on mercury, but I'm happy to hear more of what you might want to say.
If I could speak,
Sure, please go ahead.
I've had MS for 52 years. It was relapsing remitting for the first 10 years, then went into secondary progressive for the next 10 years. And then I got extremely depressed. Without a cane, I'd crawl on all fours. I went to the Shepherd Spinal Center in Atlanta. They were very good, exercise in their pool. You can do more in a pool than you can do without the pool than you do standing up. I had my mercury amalgam fillings removed. Most people don't know that there's silver fillings, mercury amalgam fillings that are 50% mercury. At the time they replace them, at the time they put them in, they're 5% mercury when they take them out. So that mercury goes someplace. I had chelation treatment with EDTA, had extreme exercise. I was on prednisone for 3 years to give me the strength to do that exercise. Tai Chi, whole bunch of things, but I really think the removal of mercury caused my improvement. I was inspired by somebody else that had recovered from their disabilities. So I know there are at least 2 MS patients that have recovered from the disabilities. My neurologist wrote a letter to the MS Society or gave me a letter to send to them. I cannot get the MS Society to even ask how many people have recovered from their disabilities. I would be in hopes that somebody would ask that question and then do a survey on those that have recovered. Thank you.
Yep. Thank you so much, Tom, for sharing. And yeah, it's very interesting to hear your experience. And I see Patty raised her hand. Patty?
Hi, I don't know if you're aware of Blue Zone certifications, and if so, or if not, I shared a picture of it. And have you had very many participants that live in these certified areas?
Thanks, Patty, for the question. I'm actually not aware of blue zones, but we do have the information on where the people live. So if it is something of interest, we can certainly look at the difference between which state, I assume you mean which state in the US they live in. Is that correct?
It's actually cities and communities. So part of the Blue Zone elements are to move naturally, have the right outlook, such as know your purpose, downshift, don't be as busy, eat wisely, and belong, family first, belong, and have your right tribes, the right positive people, positive influences.
Interesting.
I don't know if you're able to see the picture I shared, but
We do, Patty. Yep. But even myself, I never heard of that, but that's good to know. You also have 2 other questions. Would you like to bring that up to Dr. Nick, or you like me to ask her, Patty?
oh, feel free to ask. It's okay.
Yeah.
Because I believe there's some other, but one thing I wanted to mention is the gentleman who talked about mercury. I'm from the age where I have mercury fillings, and I've heard about mercury potentially impacting, but it's something I would enjoy studying for myself. Thank you.
Yep. And her second question, Dr. Nag, is actually Patty's question. She asked about, is physical therapy considered as exercise methods?
Physical therapy, yes.
Right.
When we did that, we categorized that into other, physical activity, yes. Physical therapy is definitely exercise methods.
Okay. Okay. And then he also got another question about let me find, okay, yeah. So he asked that were there any impacts or results regarding people, I mean, I guess that Western versus non-Western population. Have you looked at that at all?
Yeah, I'm very interested in looking at that, but unfortunately we didn't have enough non-Caucasian population, so we weren't able to do that analysis. But that's a very interesting question.
All right. Otherwise, I see only comments in the chat function. I just like to again give opportunities to all of the participants. You have any questions for Dr. Nang before I, kind of ask her a question? Any questions from the audiences?
I may think,
comment,
Yeah. Go
somebody
ahead.
else come. If I can comment on what Patty said, I do encourage her to look into mercury exposure. I had my first episode of MS about 6 months after I had my amalgam fillings removed and replaced to get in the Marine Corps. After having lived with MS for 52 years, I'm somewhat familiar with the trouble buttoning buttons and the gait and chest hugs, yeah, all of it, I think. But having the mercury fillings removed would be a first step to minimize your mercury exposure. But you still have mercury in your brain cells. You still have mercury in your system. You would also need to consider chelation treatment after that. And EDTA, I think, is probably one of the best chelation agents. Exercise is just unbelievably important. Tai Chi was good. Visual imaging, prayer, can't leave that out, and diet. I went on a no sugar, no obvious sugar, which was no Coke and no Diet Coke for over 3 years. And I guess that's an anti-inflammatory diet. And at the same time, I had a stick of butter and 2 raw eggs in a blender every morning. To actually give me the cholesterol for my nerve cells to heal. And while I was on no obvious sugar with a stick of butter every morning, my cholesterol didn't go up. So there must be a connection between cholesterol and sugar. And I'll be quiet.
Wow,
Mhm.
that's impressive. Yep.
I'm sorry, chat. I come up with questions as I'm thinking.
Yes.
So the study showed there were more females. And I'm wondering if there was any association, and your study probably didn't cover this, regarding menopause and the diagnosis of MS.
So we don't have that data, Patty, unfortunately. So I don't know whether you fill out any of the surveys, but it's basically just the data that's accessible. So even I'm seeing that, like with Tom asking questions about mercury, unfortunately, we can't ask all these interesting questions, even though we're all interested in finding out about this. We're trying to reduce the burden on the participant because the surveys are very long, as you probably know if you partake in any research. And so we want to make sure that we focus on the areas that the research in the literature shows that are most impactful for that. And that's why some of these questions are not yet answered.
Thank you very much. I'm very excited to see the research you've done. Very informative.
Yeah.
Thank
you both, Patty and Tom. So for the sake of time, we have a few minutes left now. I just like to kind of start wrapping up. I'd like to ask one last question. Actually, this is from the people who asked and posted the questions before when they register. So the question is, we talk about lifestyle, choices and stuff. So can you comment on what is the most important lifestyle choice for people living with MS that, can keep the, exacerbation, kind of at bay? That is the question.
So we're looking at that, we're investigating that, and our unit is finding that you need to incorporate at least 3 or more positive, healthy lifestyle behaviors to see positive benefits or optimal benefits. We can't really identify which one is the most effective, and I think that is probably due to what people's individual rates of adherence are. So if you like doing exercise or you're able to do exercise and you're likely to adopt that long term, then that is something that you're going to stick to. But the results do appear that diet and exercise are the key drivers. But we're not sure of the other ones, and that's just based on because we don't know how many people are adopting those. So yeah, do as many of the 6 as you can, and do what you're going to stick with.
Yep. All right. Yep. Well, thank you so much, Dr. Nek. I myself learned a lot from your presentation, and also, from the audiences, due to, or, from their questions as well. So, and again, thank you so much for that. And also thank you everyone for being here. I also like to thank iConquer MS for, organizing and also, promoting for this webinar event. And just like to let everyone know, after today, iConquer MS going to send out the survey to collect your feedback for the webinar today. Okay, so if you have time, please fill out the survey and let us know, how did we do. And one last thing, and I promise I will let everyone go, is kind of getting into the kind of late evening, not really late evening, it's still early evening, right? So our next Chat with Chat webinar will be on December 8th, and it's going to be at 4 o'clock US Eastern Time. So please stay tuned. We will have Dr. Deborah Mueller from Cleveland Clinic in Ohio to be our speaker on that day, again, December 8th. So please stay tuned, and we will make announcement and also send out the registration link, and hope to see you on that day again at our webinar Chat with Chat. Thank you all, and you all have a great evening. And Dr. Nek, you have a great day because it's your morning.
Thank you very
Thank you
much.
so much for such a wonderful presentation and such a wonderful study. I'm so glad to see it. Thank you very much.
Thank you.
Thank you. Thanks everyone for joining. I really appreciate your time.
Yeah. Thank you, Dr. Nek.